Welcome to the Surgical Pioneering Podcast. I'm Dr. Reza Lankarani, General Surgeon and founder of the Surgical Pioneering Podcast series. Today, I want to examine a platform that occupies an increasingly interesting position at the intersection of surgery, medical education, digital technology, and global professional collaboration, MEDtube. The important question is not simply, is MEDtube useful? The more academically relevant question is, can a large, video-centered professional platform actually contribute to higher quality surgical education? And where are its limitations compared with conventional scientific literature and peer-reviewed research? What is MEDtube? MEDtube describes itself as a professional community and medical education technology platform designed specifically for healthcare professionals. According to its current public information, the platform has exceeded 35,000 clinical educational materials and 475,000 verified healthcare professionals, with content spanning videos, images, cases, publications, events, ebooks, webinars, and e-learning across medical specialties. MEDtube.net. That scale matters, but scale alone does not establish educational quality. What makes MEDtube particularly relevant to surgery is its visual and procedural orientation. Surgery is fundamentally a visual discipline. Anatomy, tissue handling, exposure, dissection planes, operative sequencing, instrument positioning, and technical decision-making are often difficult to communicate completely through text. A well-constructed surgical video can therefore provide something a conventional article cannot: direct visualization of technique. Where MEDtube is particularly strong. From a surgical educator's perspective, the platform has several important strengths. First is visual learning. A surgeon can read a description of a laparoscopic procedure, but seeing the anatomy, the dissection, the sequence of operative steps, and the management of an unexpected finding can provide a substantially different educational experience. Second is global knowledge exchange. MEDtube's model allows physicians, universities, medical societies, and clinicians to share educational material internationally. The platform reports availability in multiple languages and describes its objective as reducing geographical, cultural, and linguistic barriers to professional medical knowledge exchange. MEDtube.net. Third is professional rather than general public positioning. MEDtube states that access is directed toward verified healthcare professionals and that different materials can have different professional access levels. MEDtube.net. That distinction is important because surgical education should occur within an appropriate professional context. Fourth is the platform's educational infrastructure. MEDtube is not simply a repository of videos. It describes an ecosystem incorporating e-learning, webinars, live educational activities, professional profiles, discussion groups, events, ebooks, and other educational tools. MEDtube.net. This creates the possibility of moving from passive viewing towards structured learning. But here is the critical academic distinction. As surgeons and researchers, we must be careful with terminology. Educational verification is not the same thing as scientific peer review. MEDtube states that uploaded materials are reviewed and verified by medical specialists, and that selected materials receive additional expert commentary. MEDtube.2. That is a meaningful quality control mechanism. However, a verified surgical video does not automatically have the evidentiary status of a randomized controlled trial, a prospective cohort study, a systematic review, or a clinical practice guideline. A video can demonstrate how a surgeon performs a procedure. It does not by itself establish whether that procedure is superior. This distinction is fundamental. A technically impressive operation may be educationally fascinating while still lacking comparative outcome data, standardized patient selection, long-term follow-up, complication reporting, or reproducible evidence of superiority. Therefore, MEDtube should complement, not replace, the scientific literature. The major opportunity: turning video into evidence-rich education. In my view, this is where MEDtube has perhaps its greatest opportunity. Imagine a surgical video accompanied by a standardized academic framework: indication, contraindications, patient selection, relevant anatomy, operative technique, alternative techniques, complications, conversion criteria, short and long-term outcomes, level of evidence, relevant guidelines and references, conflict of interest disclosure. That would transform a surgical video from merely demonstrating a procedure into a much more sophisticated educational resource. The future of digital surgical education should therefore not simply be more videos, it should be better contextualized videos. A second concern: commercial independence. There is another issue that deserves serious academic attention. MEDtube publicly describes a business model involving commercial educational projects with medical device manufacturers, pharmaceutical companies, and educational institutions, while also emphasizing transparency and unbiased content. MEDtube.net. This does not mean that commercially supported education is inherently unreliable, but it means that transparency becomes essential. For clinicians, the relevant questions should include who funded the educational activity, who created the content, were commercial interests involved, were alternative approaches presented, Are conflicts of interest disclosed? Is the educational conclusion supported by independent evidence? These questions should apply not only to MEDtube, but to digital medical education generally. The problem of review time. There is also an important editorial issue. For any professional educational platform, review quality and review speed must be balanced. A prolonged review process can frustrate authors, educators, and publishers because valuable educational material remains unavailable while waiting for expert assessment. But the answer cannot simply be to eliminate review. In medicine, particularly surgery, rapid publication without adequate clinical scrutiny can introduce another problem. Misinformation or incomplete interpretation can spread faster than it can be corrected. The better model would be a transparent, risk-stratified review system. For example, low-risk educational material could undergo expedited review. Complex operative procedures could receive specialist surgical review. Content making claims about clinical superiority could receive a higher level of evidence assessment. Commercially influenced material could receive enhanced conflict of interest review. And every submission could have a clearly communicated expected review timeline. That would address the legitimate frustration caused by delayed reviews without sacrificing patient safety principles. What are MEDtube's weaknesses? The platform's greatest strength, its enormous diversity of content, is also potentially its greatest weakness. 35,000 educational materials do not necessarily represent 35,000 equally rigorous educational resources. The educational value of a surgical demonstration depends on its content, accuracy, presenter expertise, patient selection, technical quality, and supporting evidence. There is also the possibility of selection bias. Innovative, dramatic, technically sophisticated procedures are naturally attractive to viewers. But surgical education must also teach what not to do, when not to operate, when to abandon a technique, how complications occur, and when a conventional operation is preferable to an innovative one. A mature surgical education platform should therefore make room not only for successful and impressive procedures, but also for complications, failures, limitations, negative results, and alternative strategies. My surgical assessment. So, where do I place MEDtube academically? I would describe it as a valuable digital professional education ecosystem with particular relevance to visual and procedural medical education. Its strongest contribution is not that it replaces the medical journal. It doesn't. Its strongest contribution is that it can connect visual clinical experience with a global professional learning community. For surgeons, that is potentially extremely powerful. But its educational authority should always be interpreted according to the evidence supporting the material. A surgical video can teach technique. A scientific study can evaluate outcomes. A systematic review can synthesize evidence. A guideline can translate evidence into recommendations. These are complementary functions, not interchangeable ones. The future of surgical education. And perhaps this brings us to a much larger question. The next generation of surgeons will not learn exclusively from textbooks and journal articles. They will learn from a combination of operative video, simulation, artificial intelligence, digital libraries, structured e-learning, scientific literature, mentorship, and real-world operative experience. The challenge is not simply to digitize surgical education. The challenge is to make digital surgical education scientifically rigorous, ethically responsible, transparent, and clinically useful. MEDtube is an interesting example of how far that model has already progressed. Its next opportunity is to move even further, from a large repository of professional medical content toward an increasingly evidence-structured, outcome-oriented, interactive surgical learning environment. Closing. So, my conclusion as a surgeon and researcher is straightforward. MEDtube has significant educational potential, particularly because surgery is a visual discipline, and because global professional knowledge exchange can accelerate learning. But we should not confuse accessibility, popularity, expert verification, or visual sophistication with high-level clinical evidence. The real measure of success is ultimately whether digital education helps clinicians make better informed decisions, perform procedures more safely, understand complications more effectively, and improve patient outcomes. That should be the standard by which we evaluate every new technology in surgical education. I'm Dr. Reza Lankarani, general surgeon and founder of the Surgical Pioneering podcast series. This has been another evidence-first discussion in surgical pioneering. Until next time, keep questioning established practice, keep examining the evidence, and keep pioneering better surgery.